Good afternoon and welcome. Thank you for joining us today for our training in honor of National Recovery Month, Science of Addiction and Recovery Lived Experience panel, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. I am happy to introduce our presenter for today, Dr. Lawrence Bryant. Dr. Bryant has more than 32 years in long-term recovery. Dr. Bryant brings a plethora of experience and knowledge dealing with substance use disorders, HIV/AIDS, prevention and education, diversity, equity and inclusion training, anti-racism training, and sexual orientation education. He successfully developed and implemented a statewide strategic plan for Georgia in response to the opiate and prescription drug overdose epidemic. As a part-time assistant professor at Kennesaw State and Capella University, Dr. Bryant teaches courses in substance use disorders, health and wellness, and does research and training in the areas of substance use disorder prevention, treatment, and recovery. It is my pleasure to turn it over to Dr. Bryant to begin the presentation. Thank you, Dr. Bryant.
And certainly, I want to say thank you to the Center of Excellence for Behavioral Health and Nursing Facilities for allowing me an opportunity to have a conversation regarding the science of addiction, recovery, and a lived experience panel. And so the work that the Center of Excellence does is nothing short of miraculous. And so I want to just say to them again, thank you for the honor of being able to have a space to talk about this very important topic. And I must give a shout out to the tireless work that Nikki Harris has done. She's been a drum major for this issue, and I admire her so much. And so I just want to say thank you again for allowing us the opportunity to be able to do this as well. And of course, our other individuals who work behind the scenes, Derek, thank you so much for your work, and the others that have provided IT. We could not have done this without you. So in terms of objectives, what we want to learn, and most importantly, we really want to provide information for you that you can take with you, that you can use for your day-to-day interactions to provide input, interventions, and services that really make a difference in the lives of nursing home residents. So we'll talk a little bit about the science of addiction and the implications for that, as well as explore some complex kinds of needs of nursing home residents with substance use disorder. We'll assess and evaluate some learning strategies that nursing facility staff can use in working with residents. And I really want to highlight this third objective because it's very important. We want you to be able to leave here with some information, some knowledge, and some skills that you can impart to your day-to-day interactions and, again, interventions with residents. And also, we will top it off with a panel discussion with lived experience. We want you all to be able to see real live individuals who are in long-term recovery, and certainly the implications for your own work as well. So buckle up your seatbelts. This is going to be a very, very interesting ride. And so firstly, I want to contextualize what we mean by addiction. And there are many different definitions out there, but this particular definition, I think, is very comprehensive, is very succinct, and is very poignant. And this is from the American Society of Addictive Medicine. And they go on to say that addiction is a treatable, chronic, medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. So let's just break that down just a little bit, because firstly, what it's saying here is that addiction is treatable. So those sort of old ways of thinking that, once a person is addicted, they will always be addicted, that just is not true. So addiction is treatable. Also, it is a chronic medical disease, and we're going to explore that in more depth. And this is one thing that I really, really want to make very clear in terms of discerning addiction as a medical disease as opposed to some other entity. So in addition to that, it also involves complex interactions among brain circuits. So there is a change in brain chemistry when we're talking about addiction, and we'll go a little bit more in depth with that as well. It also has a genetic component to it, an environmental component, and of course, a lived experience component as well. So this is the definition that I want you to arm yourself with as we move through the presentation. So let's look at the brain. And here is where we can begin to understand and see, firstly, that addiction is a biochemical. It is a brain disorder, very similar, for example, to other diseases such as asthma, for example, such as cystic fibrosis, such as diabetes. And so when we reconceptualize what we look at and what we mean by addiction, we can begin to change our outlook on addiction. And so in terms of what happens in the brain, and so as you can see in this diagram, there are external kinds of things that impact the brain and the brain function. And so when we look at the brain, we look at neurons and neurotransmitters as well as receptors. So for example, when there's some kind of external stimulus that happens, you then have neurons, which then takes these messages along a synapses, which is what we call a neurotransmitter. And we'll talk a little bit more about a neurotransmitter. But when these messages are taken along this pathway, they then send additional messages through these neurotransmitters and also through these receptors, which then invoke a response or a behavior. But if we look further on this next slide, we see that there are certain things that happen when, for example, we look at external kinds of things that happen. For example, you'll see two boxes here. One, it looks at what happens when we're eating food or when there's some kind of external kind of stimulus that just makes us feel good. And we look at the box on the right-hand side, we see that when substances are interjected, that whole process is exacerbated. So for example, such as myself, I love food, I am a foodie. And for example, I'm from Philadelphia. And so every time I go back to Philadelphia, the one thing that excites me, that gets my dopamine, and that's the neurotransmitter that we're talking about here. When I get that going, before I even get to Philadelphia, when I'm on the airplane, all I can think about is a Philadelphia cheesesteak. That makes me feel good. It's one of the first things that happens when I take a trip to Philadelphia. And so when you look at this box on the left, and when you look at dopamine, again, dopamine is the neurotransmitter, which transmit different kinds of signs that cause a reaction. And normally when we eat food or when we have sex or whatever those normal kinds of things that happen that makes us feel good, you've got these little balls here. And these balls really represent dopamine. And so the normal mechanism is, for these small amounts of dopamine to be elicited when we do something, for example, like eat food. In contrast, when we look at the box on the right-hand side, whenever there are substances introduced, and this example utilizes cocaine, that whole dopamine process is exacerbated. It's expanded. In fact, it becomes so expansive that the impulses become very erratic. There's no sort of systematic organization for eliciting response. And so with the intervention or interspersion of substances, this dopamine process is over-exacerbated to the point where our brain circuit wants to duplicate this process all the time. And so this exaggerated process leads to what we call cravings. And so these cravings are to the point where with certain substances, we want to get back to that over-exaggerated kind of mechanism with dopamine. And that's where the substance use disorder happens. And in recovery circles, oftentimes we'll say it's those cravings that cause us to want more, to chase the substance, regardless of what impact it may or may not have on our lives behaviorally. And we'll talk a little bit more about that as we move forward. But what I want to make clear is when we talk about substance use disorder as a brain disorder, we can look at perception here. And on one hand, we can look at it from a moral perspective. So in other words, if we look at it from that perspective, it then means that our attitudes, our interactions may be different. We may think, well, they did this themselves. They're responsible for their own behavior. So I really don't have a lot of empathy or a lot of feelings about those individuals because they caused this themselves. But when we look at this as a brain disorder, as you can see in that right-hand box, we treat this as if it was any other disorder, like asthma, like diabetes, which then elicited a response that's more empathetic, a response that really says that instead of, for example, stigma or something that may lead to incarcerations, we really look at treatment and we look at interventions that support recovery in an individual when we're looking at this as a brain disorder. And so as we move along to this next slide, when we're talking about substances, and one of the things that's important here is language. We want to be sure, first of all, that we are identifying different substances based on that substance. So when we look at, for example, alcohol, we identify and say that this is a person, and we're talking about person-centered here. And so a person with an alcohol use disorder, if their substance is alcohol. If their substance are opioid, we say a person with a opioid use disorder, a person with a tobacco use disorder, a person with a marijuana use disorder, and cocaine use disorder. And so that really, first of all, identifies a specific substance as opposed to just a generalized substance use disorder when we are interacting and when we are talking about a variety of different kinds of substances. And also understand that oftentimes individuals may have polysubstance use, which means that they are engaged or are using more than one kind of substance. And so as we move on, when we look at some long-term effects of substance use, you can see a variety of different kinds of issues that come up. And so, again, when we're looking at, for example, the physical changes to the brain region that govern a variety of different kinds of responses, we'll see that substances impact judgment, decision-making, behavioral control. So in other words, individuals may engage, when we talk about that craving, when we go back to that particular diagram, those cravings cause people to do things differently than they ordinarily would do. So for example, finances. A person that may be having a substance use disorder may be financially unstable as a direct result of their substance use. Decision making, decisions on, for example, making sure that you're responsible enough to make it to work and those other things. So substance use oftentimes interfere with these physical regions of the brain. And ideally, what we say is what makes one addicted is not necessarily the substance that they use, because everybody who uses substances does not become addicted. I want to make that very clear. As a matter of fact, a large majority of people who use substances do not become addicted. But what makes a person have a substance use disorder is what happens after they take the substances. Are they able to maintain their family? Are they able to maintain a job? Are they able to be financially responsible? So interference with those daily activities is what really sets this population apart. And so moving forward to the next couple of slides. So this next slide really does illuminate what we mean by looking at some signs, particularly in nursing home residents. And so I want to just take a moment here, because it's very, very important that, number one, we begin to be able to observe signs that may be consistent with substance use disorder. And what's most important, not only observe these signs, but also document these signs for example, the next shift or the oncoming person, so that they are aware of maybe some behavioral kinds of changes that are not necessarily always associated with the individual. So for example, frequent leaves of absence or leaving the facility, particularly without the facility knowledge. Others are, for example, neglect appearance. Perhaps the person is not as hygienic as they normally are. And those kinds of things also should be observed, acknowledged, and also documented as well. And also other things such as unexplained drowsiness, slurred speech, lack of coordination. These are all changes that should be observed by the staff. Again, not only observed, but also documented so that it can be communicated to the appropriate personnel. And in the next couple of slides, I really want you to take notice here, because the other thing that's important, particularly for staff, and not just nursing staff, but any staff member, we can begin to change our language. And we can also become agents of destigmatization. And as we change our language from stigmatized language to more affirming language, we see that really does make the difference in our interactions with our residents. And so the next slide, we really want to talk about affirming language when we're talking about substance use disorder. A language, again, that's more respectful and more culturally appropriate. So let's just look at this next slide. I'm not going to go over every single one of them, but this is a slide, and you'll get these slides afterwards, I'm hoping. And I always print this particular slide out because language is changing so frequently that oftentimes I can't keep up with it myself, and other times I just forget. So for example, I'll just go over a few. Instead of this, on the left-hand side, there's the stigmatizing language. On the right-hand side, it is the preferred, more affirming language. So instead of the term abuser, we, again, person-centered language, a person with or suffering from a substance use disorder. Here's the big one. We no longer refer to our residents or their family members or anyone else as an addict. We refer to them, again, person-centered language, a person with a substance use disorder. Alcoholic, we don't describe a person as an alcoholic, but a person with, again, identifying the particular disorder, a person with an alcohol use disorder. And this last one I really want to just illuminate, and that is oftentimes we say a person who's not using, they're clean. But that really has some very stigmatizing overtones. So instead of that, we say a person that is obstinance or abstinent. And so you can see some of these others. I'm not going to go into all of them in detail, but here we as staff, as anybody who's working with residents or this population and their family, we can begin to change our language from stigmatized language to language that's more affirming. And on this next slide, it really gives us some tips for nursing home staff. And when we say staff, that's anyone, whether it's someone from environmental services that may be cleaning the room, but anyone who has contact or interaction with the patient really should begin to promote a culture where we become more acknowledgeable, more aware about substance use disorder. So we ensure that staff at all levels, again, in the nursing facilities can begin to recognize the signs and symptoms of substance use. And so again, this can be through education, and I'm hoping that it will be for you all more than just a one-time one half an hour webinar, but an ongoing kind of education process. Again, be supportive. If you think someone needs help for substance use disorder, we're going to go over in this last slide some tips that we can engage in terms of providing the support, providing the help that these residents may need from a respectful and from an affirming position. And also, oftentimes within our facilities, we find that individuals may come in with a totally different kind of medical disease or a medical problem, but then may also have a substance use disorder as well. So in the next slide, we'll talk a little bit more about that. But again, this last point, I really want to bring home that everyone can play a role to help residents in the recovery process, including caregivers and family members. And so in this last slide, we really want to bring home some action-oriented kinds of things that you can do in moving forward in terms of our interactions, our interventions with individuals who have substance use disorder. So you can see some of the points here that's very important. But one of the first things that we can do is be more attentive with our screening. So here you'll see how screening can really identify potential problems. And one of what I consider a really evidence-based kind of screening tool is the SBIRT. That stands for Screening, Brief Intervention, Referral, and Treatment. And this is really a useful tool so that we can begin to identify risky patterns of substance use disorder. It also allows a mechanism so that we can begin to connect people with resources, with services, other kinds of support. And also we can begin to identify if those persons have identified as having a substance use disorder, being really, really more aware and knowledgeable of things, for example, like fall precautions, things like other kinds of diseases that may be associated with substance use disorder as well. And the other thing is very, very important, because oftentimes it's the nurses or whoever will be doing the initial intake and doing the history. It's important that we be very attentive about our history taking. So, for example, using elements of motivational interviewing so that we are not looking down on individuals or being judgmental. And oftentimes residents can tell if professionals are being judgmental. We want to be as non-judgmental. We want to be as supportive as we possibly can while gleaning very important information from our residents. And so central to motivational interviewing is empathy, really, really being able to communicate with a level, again, where we're not being judgmental, where we're not being disrespectful, but we're helping the resident be open and as comfortable as they can so that we can also be able to get the necessary information. And primary, when we're talking about motivational interviewing, is reflective listening, really intentionally listening to our residents and really listening from a perspective of perspective of empathy. And again, in the last couple of minutes, just want to go over a couple of more things. So in addition to staff members and administrators providing webinars like this and information like this, it's important to identify our own biases. Everyone comes to the table with a bias. And of course, we hear this topic all the time, cultural competence. But I will refer you to the element of cultural humility. And what that says is for all of us, that we begin not only to identify our own biases, but that we take on an attitude and a disposition of lifelong learning about different substances, learning about addiction, learning about a variety of trends that's happening now throughout our country in terms of substance use disorder. Any kind of education kind of online webinars. There are many free online webinars that we can continue to educate ourselves, not just once a year, not just once a quarter, but this can be an ongoing process of cultural humility. Because, for example, oftentimes, particularly our residents that may have a substance use disorder, holidays can be a very challenging time for these individuals. So we want to be sure that perhaps we are maybe more aware during this time, maybe engage in conversations with our residents so that, for example, when they're going out on leave, that, they understand perhaps, what or have any concerns that they may have, that they will convey those to you as well. And so lastly, I want to say that when we have individuals within our facility that may or may not have a substance use disorder, the facility itself may be a perfect place, for example, to host 12-step meetings. And so this is something that is right on your facility. Now, I want to make clear, when we're talking about 12-step programs, 12-step programs are not associated with the institution, but just house meetings at that institution, and they also pay for the meeting space. But the benefit here is if you have clients, then they don't have to go out. They have these meetings opportunities right there in your institution. And of course, with 12-step, whether it's Alcoholics Anonymous, whether it's Narcotics Anonymous, there are meeting places all over the country. So almost a hop and a skip, wherever you are, there's always a meeting place for these individuals. So it then becomes very important that we have referral of information for different resources. But at the end of the day, we want to provide first of all, a safe environment for not only our residents, but for our resident families, and not just the individuals that may or may not have a substance use disorder, but also other residents. You want to be sure that they are safe. And lastly, I want to say that one of the things that can help this process is to have very succinct policies regarding substance use in your particular facilities. And also what will happen if these rules are broken. They should be written. Everyone within the facility should know what these guidelines and rules are, because again, you want persons to be able to react and interact with individuals who may have a substance use disorder, so that they have guidelines in terms of what they should or should not be doing. So I'm going to close the presentation with that. And again, I'm a person in long-term recovery, as is our other panelist, and I'll introduce him very, very shortly. But, as Nikki expressed, I have all of these professional kinds of accolades, and I'm really honored that I've been able, with the support for myself of a 12-step program. And so August the 16th, 2023, which was last month, we, and I always say we, celebrated 32 years in long-term recovery. The journey has been sometimes arduous. Sometimes there have been barriers to my recovery, but I'm forever grateful that I've been able to be delivered from the clutches of active addiction. And I'm one of those persons that mostly during the 80s, addiction took me down a very, very dark road. And the other point that I want to make is that anyone can become addicted. At that point, I was a respiratory, and I want to go back to 1981, 1982. I was a respiratory therapist. I was a professional. I was the last person in the world who thought, even for myself, that I would ever become addicted to any substance. You couldn't even get me in my 20s to even smoke marijuana. But something happened in my life that I never, ever expected. And that was a nervous breakdown because of the breakup of a relationship. And that's what started my journey into addiction. And if I had known what I know now, if I could have gotten some psychological help, but that just was not in my vocabulary. It wasn't something that I even thought about. All I wanted was the absence of pain. I was in such agony. And it was one of the only times in my life where I ever entertained suicide. And I didn't know what to do. And my only thought was, whatever it took to get out of this pain, I would do it. And so I sought substances, never knowing the risk associated with substances. And so it took me down a road of homelessness. It took me down a road of depravity. And at one point in my life, sleeping in my car for days at a time, sleeping in the park in West Hollywood, California. That's where I lived during that time. So my addiction took me down a very, very, very dark road. And it wasn't until an individual came to me one day, I just didn't know what to do. I knew that I didn't want to live my life the way that I was living it, but I just didn't have a clue of what to do and how to get out of it. And an individual by the name of Bishop Carl Beam reached out to me one day, and he said something to me that just set a light bulb in motion. And while it didn't happen just then, it would take me many more years, but it was a catalyst. It was a light that helped me to see that there was another way. He grabbed my hand and he prayed with me, and he said, there is another way. And he introduced me to this 12-step program. And I tell you, it took me maybe about 5 or 6 more years, but ultimately it was the 12-step program that changed my life, that took me in a completely different direction, such that I was able to not only have a degree in respiratory therapy, but in my early recovery. Education was just so important to me because I thought that I was going to die with a needle in my arm. I thought that there was just no way out. But this support from 12-Step really helped me see my worth, really helped me see my value. And so they encouraged me to go back to school and get a bachelor's. So I have a bachelor's in social work. I had people who just pushed me in my 12-step program, who then allowed me to go back to school and get a master's. And then on top of that, really pushed me to go back and even get a doctorate, something that I never thought I'd be able to do. But what this really does illuminate is that there are so many benefits to recovery. And even the interventions that we do, you may not see the fruits of your labor just then. But nevertheless, we still have to be a conduit of, again, destigmatization, a conduit of hope for individuals. And in our residents and those individuals that have a substance use disorder, we can also be cheerleaders for these individuals to help them see and understand that there is another way to live. Now, while we can't make anybody recover. A person has to want to do it. But those individuals that may be in our facilities, perhaps they may want to do it. And so we then can be a catalyst for change and impact on these individuals. Now, while substance use disorder is a lifelong disease, I still am very, very involved in the 12-step fellowship. I tell you, there's just been no greater joy than to go to a world convention of Narcotics Anonymous. As a matter of fact, the last convention we had was in Orlando. But just to know that people from all over the world are in recovery, whether it's from Russia, from China, from Africa, we all convene together and we encourage one another, we support one another in the recovery movement. Now, I say that to also say that everyone doesn't recover the same way. There are many roads to recovery. I just chose the road of a 12-step program, and I still do. And I've been totally abstinent from any mind or mood altering chemicals for 32 years. But there are other ways to recover. There's other areas such as risk reduction kinds of processes that are available. Smart recovery is available. Some people recover in church. Some people recover, they just stop using. And so the 12-step program doesn't have a monopoly on recovery, but nevertheless, we as professionals, as persons that are working with these residents, we can begin to instill the same kind of hope that was given to me 32 years ago. We can begin to also share that same kind of hope onto other people. And the one thing that I want to say is I didn't do any of this alone. uh, I had the help of people whose only desire was to help me achieve the same things that they got. And I just want to say this other panelist is someone who also took me by the hand and gave me hope and nurtured me and loved me and sponsored me through the years in my recovery. And we always say in recovery circles that the therapeutic value of one recovering person with another recovering person is unparalleled. And this next person, I'm going to ask him to come off of mute and show his video. His name is Victor, and I have so much respect for him. I have so much admiration for him. But again, he has been a drum major for recovery, not just in Atlanta, but across the country. And so with no further ado, let's bring up Victor. Victor, it's your show.
Good afternoon, everyone. Hey, Larry, I'm gonna need my Dr. Lawrence, I'm gonna need my $50 back for paying for that introduction.
I got you.
First and foremost, I want to thank God and thank everyone on this training. It's an honor and it's a privilege to answer a call to help someone get on the road to recovery. I'm not up on the new lingo that they use, professional lingo. My name is Victor. I'm an addict. And as of today, I have 35 years, 11 months, and 14 days clean. So on the 30th of this month, I have 36 years as a substance abuse user in long-term recovery. And I'm overwhelmed. I was asked to do this. Thank the Center for Excellence for Behavioral Health and Nursing Facility for asking Dr. Lawrence to do this and him asking me to do this. Anytime he asks me to show up for him, I will, because he always shows up for me. So give you a little history about myself. I'm here in Atlanta, Georgia. I was born in Columbus, Georgia, but I wasn't raised in Columbus, Georgia. I was raised in New York. My mother moved to New York in 1967. At the age of 4, I moved to New York. And they wasn't kind of people that was from the South. They call us country bumpkins and different stuff like that. We used to say like filling station and sack, and they was like, that's not, they use politically correct now, but that wasn't the correct thing to do. So from that experience and experience of the messages that I received at home from a single parent mother that had little education from the South, and she did the best that she could, you know. So I didn't feel worthy. I had very low self-esteem, low self-worth, and I just wanted to fit in. I was just sitting here as Dr. Lawrence was giving his presentation, and I could remember being alone as a child. I always kept good company by myself, but when I went to go fit in with other people, that's when I got into trouble. I started using marijuana at the age of 13, and at the age of 24, that was about to come to an end. I'm gonna give you the short version because I want to hear from the questions that you guys have. So at the age of 24, my daughter, I had 3 kids at this time. I had a daughter that was 22 months. I had a daughter that was 4 years old, and I had a son that was 3. And my daughter that was 22 months tripped over my foot, and she hit her head in the bathroom. And a few months later, she died. And I blame myself for her death. So I was running from the voices that I was hearing in my head. So back in the 80s, they used to say cocaine was a non-addictive drug. And we all know that's a lie now. So I started climbing the ladder, if you will, of drug use, you know, starting with the alcohol and going up the ladder, right? And by the time I was 24, when my daughter tripped over my foot, but that wasn't enough to stop me from using. What happened was I woke up and the police was standing over me, and it was September, and my mother was like, "You getting out of here." And I knew I had to come up with something because she was tired of the lies, and it was about to get cold in New York, and I had a fear of being a bum. I had a fear of being homeless. So I went to, they used to call it a therapeutic community back in 1987. And I went there not knowing what I was getting myself into. So while I was there, I was hospitalized 3 times. So I guess they didn't want me to pass away in their facility. So I wound up going back to the outpatient program that I started from. And while I was there, I met my first wife. We was in treatment together, and she got pregnant. I had another daughter, and by this time I had started working on myself. So those voices that I heard in the beginning started to decrease because I started taking responsibility for my recovery. So in 2002, I came to a world convention in Atlanta, and I moved back here in 2003 from 1967. When I got clean, I was 24 years of age. I just celebrated in January. I just turned 60. And where I come from, that's a miracle, because where I come from, either you got killed, you go to prison, or you still out there on drugs. And it's pitiful because I had 33 years clean, and I went back, and the same guy is standing on the same corner, right? I was fortunate enough to go and get a associate degree. I didn't know that what I was signing up for. I have an associate degree in occupational therapy. I'm a priest in the Yoruba faith. I'm a priest in the Ancestor Society. I'm a homeowner. I'm remarried. I'm retired, but I'm dealing with chronic pain. I got hurt on my job in 1997, and had very bad, serious back issues. So in 2010, I had gastric bypass, not only for vanity purposes, but for health issues also, right? Diabetes running my family, high blood pressure running my family. And we talked about Dr. Lawrence talked about the other substance abuses. Food is a drug. If you use it to the extent that it have you having health issues. So I come down to Atlanta, and I came, but I didn't really know why I came, but I know it was bigger than me. And that higher power that I believe in was nudging me, right? So I didn't know by moving to Georgia that I would go to Africa twice, right? I would be initiated as a priest. Like when I went back to Africa, I thought that was a reconnection to the motherland. And when I got there, this might sound funny, but it's true. I kissed the ground because it meant that much to me. But if you have to take opioids, I had to take opioids for my back. I just had 2 back-to-back back surgeries. I had a back surgery in 2021, and I didn't follow the doctor's instructions. So I had to have another surgery in 2022. So they said it takes a year to heal. So August made a year. So I'm still in pain. I'm still having issues, right? And it's getting worse now. So now I might have to have 2 hip replacements. I will have to have 2 hip replacements because I was with the back pain, I was favoring my right side over my left. But now my left hip is on bone. So if you have to take opioids, let somebody give the opioids to somebody. Let somebody hold them, right? Because as much as I think I can be responsible, I don't want to play myself out of pocket. So if you have to take your medications, take them as prescribed, inform your doctor that you are a person in long-term recovery. And I'm gonna keep this short brief. Thank you, because I want to hear the questions and the answers. Thank you so much.
Thank you so much, Victor. And of course, you know, there's an old saying, what comes from the heart reaches the heart. And so now we want to open this up for questions and answers. And we will have, I think, Nikki that will actually look in the chat and see what we have. And so while she is coming up with some of the questions, I just have 5 more things that I just want to say, things that you can put in your pocketbook to take with you. Very, very important, nursing facilities, medication and equipment storage is important. And I know that there are times when my mom was in a long-term facility, oftentimes the medication cart was sort of just left like outside unattended. We want to be sure that those are locked up. All meds, including needles, equipment, are also locked up. And secondly, those individuals that actually share with you some of their personal struggles, please maintain their confidentiality. That is also a mandate of HIPAA, but it is just a way that individuals can feel safe when they know they can talk to you and that it will be kept in confidence. Also, very, very important, particularly those individuals that are coming into facilities that may already be on, for example, opioids. In the hospital where I work, every person that comes in that has medications has to leave those medications at the nursing station. They cannot have medications at their bedside. And so that is a safety mechanism, because if they're on medications in the hospital or in the facility, but yet and still they're taking their home medication, that can cause problems. And you just never know whether or not the medication that they have may be laced with something like fentanyl or something like that. So you really, really want to be cautious about that. And also, lastly, we're seeing a migration of younger persons in nursing homes. So it's not just the elders, but also a younger population that, again, may be coming in with substance use disorder, and we really have to be attentive to their issues as well. And so I'm eager for questions. It is your time to shine.
All right. Thank you, Dr. Bryant.